Good afternoon. It's my pleasure to be here today, and I would like to thank the organizing committee for this opportunity. My talk about the approach to elevated muscle enzymes. So I will go ahead with brief introduction, and I will go ahead with a case-based approach. It's a broad topic. We will focus more on what we are encountering in our daily practice and when to refer to rheumatology. So skeletal muscle is a rich source of skeletal enzymes, and the common used one is the creatine kinase, which is CK. Other enzymes is important, which is AST, ALT, LDH, aldolase. So we should not forget about them when we are evaluating a patient that we need to send for muscle enzymes. So the important part, is there a muscle weakness if we see this elevation of muscle enzymes? So what is a muscle weakness? Is inability to perform a single repetition of a specific task requiring muscle use. What is fatigue? It is inability to continue performing a specific task after a multiple repetition. And what is myalgia? It's a muscle pain at rest or associated with activity. Sensory loss, it's more favoring neurology part. So when we are dealing with elevated muscle enzyme, we had to go through a thorough history and physical examination. Basic labs can close the loops. But sometimes if it is still, we don't know what's the reason behind all of that, special tests and further investigation need to be considered. To start with the first case, 27-year-old local male, healthy, and he presented with a 3-day history of generalized body ache and bilateral upper proximal myalgia. It started in 23rd of December, and 3 days later, he presented to our emergency department. So his symptoms started after rejoining the gym for weightlifting. Patient reported doing weightlifting the first day with the lower limb, the second day with the upper limb, and had after that the proximal muscle pain with no weakness and no lower limb involvement. He's used to have a regular exercise for the past 2 years. It was associated with 1-day hematuria. Family history, basically diabetic and hypertension, and no known autoimmune disease. Not known to have any allergy, and the medication intermittently with magnesium omega-3 multivitamin supplements. He's non-smoker, non-alcoholic, married. So on physical examination, vitally he was stable with no weakness on upper or lower limbs and generalized muscle tenderness more at the upper proximal limbs without joint swelling or rash. Remaining of examination were unremarkable. So basic lab shows the normal urea electrolytes, normal CRP, and hepatitis B and C negative, which is our basic labs. The muscle enzyme shows CK more than 22,000, and more than 3 times AST elevation of 632, ALT of 155, and the LDH of 414. Urinalysis shows 4 plus RBC. So basically, it was a straightforward case, and patient was labeled as rhabdomyolysis and treated supportively with the pain management and hydration. So on that part, the rhabdomyolysis, it can be secondary to a vigorous exercise, medication, infections, or metabolic derangement. And the CK level can peak within few hours, and it can reach maximum up to 3 days. Cessation of this vigorous exercise or the inciting factor can eliminate all the symptoms and normalize the enzymes. And the treatment is usually supportive, and symptoms gradually improved. So moving to case 2, which I need your help on that. This patient is a 45-year-old obese male with muscle weakness. His history only diabetes, hypertension, and gout. His medication was metformin, amlodipine, allopurinol, and colchicine. 2 weeks prior to his presentation, he was diagnosed with H. pylori infection and put on omeprazole, amoxicillin, and clarithromycin. During the 2nd week of triple therapy, he reported worsening generalized myalgia, and the CK level was elevated of 1,000, mild elevation of AST of 55 and ALT of 70 with normal renal function and CRP. So which of the following medication would increase his or develop such a condition? You can raise your hand. Who will go with amoxicillin? Who will go with clarithromycin? Okay, 5. Who will go with metformin? And who will go with omeprazole? The majority. So I will go with clarithromycin, and the use of it's important to realize regarding drug-drug interaction. So the use of colchicine and clarithromycin increase the risk of colchicine myopathy and can lead to mild, severe, and even sometimes rhabdomyolysis. And the mechanism of this interaction is related to the inhibition of cytochrome P450, and the P-glycoprotein will raise the colchicine level in the body and will have more side effects. And this can be accentuated if the patient have a renal insufficiency. So this is the drug associated with myopathy, as I'm listing it here, and I believe there is more. But the first four we are encountering very frequently from rheumatology aspects: statins, glucocorticoids, hydroxychloroquine, colchicine, and the lists are longer. So I will focus more on statin, as you are dealing with this more in your clinical and daily practice. Statin-associated muscle symptoms are the most common side effect and sometimes can lead to statin discontinuation. And the symptoms might range from mild, moderate, and can have a variety of symptoms in your clinical daily practice, and it has been reported in a quarter of patients receiving statin therapy. This is the list of statin intensity ranging from low to high, and the blue shades is the hydrophilic agents, and the rest are the lipophilic. And we used to know that the lipophilic, some evidence shows that the lipophilic statins more associated with muscle symptoms, but the recent one, meta-analysis done by Erwin, found that no significant association between lipophilic or hydrophilic statin and the skeletal muscle events. So do we have a gold standard to diagnose any patients while they have statin having such a presentation? We usually don't rely much on the muscle enzymes, and there is a clinical index score that you can rely on, and which is independent of creatinine kinase elevation. But we have to put every time in our mind other possible causes, such as recent physical exertions, metabolic like hypothyroidism, concurrent illnesses, drug-drug interaction. Nowadays, there is a loads of apps that it can show the drug-drug interaction, and some hospital already, if you put the medication, it will show the interaction in the system. So these are the list of a drug-drug interaction with the statin. It's very long list, and no one can memorize it. But this is the clinical index, which rely basically on the location and pattern of muscle weakness, and when it is starting since you start the statin, and if there is a symptom improving while you are stopping the medication, and if there is a re-challenge in the future. And by the end, if it is more likely to suggest it's statin-related or not. So another important entity I want to raise, which what I just mentioned is the toxic or self-limiting statin myopathy. There is another form which is very rare, which is statin-associated autoimmune necrotizing myopathy, which is always will come with weakness, and this can be after years of using a statin. So the only thing that we see is elevation of muscle enzyme, and we have to send a specific antibody, which is the HMGCR. And even if you stop the medications, the weakness and the symptoms will persist. So this is a rare entity in comparison to the self-limited statin myopathy, which when you are stopping the medications, there is an improvement in symptoms. So what are the strategies to increase the statin tolerance? So either you switch the brands, you lower the dose, or you decrease the frequency. And sometimes, I'm not sure whether you are using, you can ask the patient to have a symptom diary between switching on and off and see if the symptoms are related to the medication or not. So moving to the last case, this is a 54-year-old female. Her presentation started in January 2022 with a hand rash and alopecia. I will show you the picture. And then 6 months later, she started having unintentional weight loss of 5 kg with generalized body ache. Later on, she presented in August with a pleuritic chest pain and dyspnea to the ED and diagnosed with unprovoked pulmonary embolism and put on rivaroxaban. 1 month prior to her presentation to the hospital, she reported bilateral proximal shoulder weakness and stiffness with difficulty washing her hair in the shower. And at the day of presentation, in addition, she reported profound fatigue and were unable to do her daily activity. So she denies joint pain or dysphagia and no personal or family history of autoimmune disease. She was vitally stable with patchy non-scarring alopecia, no oral ulcer, no cervical lymph node. On MSK examination, nail fold capillaries were quite prominent with Gottran sign, which is the reddish erythema at the dorsum of the hand, and no signs of synovitis. There was a proximal muscle weakness of 3+, and the remaining of examination was unremarkable. This is the patient's picture, which you can see that the erythema around the metacarpal pharyngeal joints, proximal interpharyngeal joints, and the distal interpharyngeal joints, and the prominent nail fold capillaries. This is her basic lab, so during her different timing of presentation shows normal urea electrolyte. WBC was ranging between 2.9 and 3.6, and she was anemic at 10, and CRP was 7. And the muscle enzyme, interestingly, CK was normal, mild elevation of AST of 73, ALT of 86, and the LDH of 276. So the admitting team, they proceeded with the CTT panel, which is the ANA for screening of autoimmune condition, which came up positive of ANA positive 1 to 320, with elevation of ESR of 44, and myositis panel was sent, which came up positive for anti-Me antibody. So the patient was labeled as an idiopathic inflammatory myopathy, which is a dermatomyositis in her case. This is a group of autoimmune syndrome characterized by proximal muscle weakness and skeletal muscle inflammation. The most common subclassification is polymyositis, dermatomyositis, and including body myositis. But other subsets are emerging nowadays, which is necrotizing myopathy, overlap myositis with other autoimmune condition, and cancer-associated myositis. So this is our old classification criteria, Bohan and Peter classification, 1975, where they were focusing basically on polymyositis, dermatomyositis, and including body myositis. And you can see all of them will have a weakness, but for polymyositis and dermatitis more proximal, the inclusion body myositis starting distally. And they all have elevation in the muscle enzyme, and the differentiation in dermatomyositis and the rest of the classification is the presence of either rash or calcinosis. There is another updated one by the European and American Society for Rheumatology in 2017, focusing basically to differentiate if the patient have a biopsy or not, but the same, like focusing on muscle weakness, skin manifestation, lab measurement, especially the enzymes that I mentioned earlier, and the muscle biopsy, and they included one antibody from the myositis panel. So, as I mentioned, it is more symmetrical proximal weakness, and usually the characteristic of inflammatory myositis is fluctuating in severity, but it's chronic, while in metabolic myopathy, it is intermittent weakness, worse with activity. If there is any focal weakness or sensory loss, this will lead to neurological causes more. So back to the case. So does the patient have a skin rash? As I mentioned, yes, the Gottran sign. This is a Gottran sign, or we can say a papule. And if the rash around the eye, it's the heliotrope rash. We have the rash at the lateral thigh. We call it Holster sign. And the periangular telangiectasia, or thickened and the cuticle. And either the rash can be at the lateral aspect of the shoulder. And the Schawel sign either at the V-shaped anterior chest or the posterior upper back. This is the patient's image. So does the patient have a muscle involvement? Yes, as we described as a proximal shoulder weakness, elevated muscle enzyme, as we mentioned, and she was having a myopathic changes in the EMG with edema around the shoulder MRI. We didn't proceed with the biopsy. So the next step we have to ask is, does the patient have any extramuscular manifestation, which we need to target our medication based on the overall picture. Apart from the cutaneous, she didn't have any, but it's interesting to mention that dysphagia, it can be in any inflammatory myositis. It's important to ask the patient itself, but if you suspect it, you can do any modality like electrophysiogram. It is a difficult to treat condition. Cardiomyopathy, generally asymptomatic. At least if you suspect something, you can have a baseline echo. Lung involvement, we are encountering a lot of interstitial lung disease, either acute, subacute, and chronic. And respiratory muscle weakness, it's important to pay attention on that. If you're suspecting any lung involvement, you can send for PFT or baseline HRCT with the help of pulmoteam. Arthritis can present similarly to rheumatoid arthritis, and it might be the first presentation for the patient. You might ask further regarding rhinoid, systematic feature, rash, or calcinosis as well. So back to the patient. Does the patient have any myositis-specific antibody? Which she had, which is anti-me antibody. We have loads of antibody, and it has been nicely mentioned earlier in the morning. And the antibody that we have in myositis, we have a specific and associated. Associated, it can be with other autoimmune condition. Specific, it might lead us with a myositis antibody. So what's the importance of having this antibody? They define the patient subgroup. They guide us in treatment most of the time. They demonstrate an increased risk of malignancy in certain antibody, and it supports prediction of outcome. So this is a nice image. So these are the antibody that we are usually rely on. Our patients having anti-Me2, and it's morely associated with the cutaneous manifestation and mild to moderate myositis presentation. Dermatomyositis by itself is associated with cancer. So it has been presented in 10 to 20% of adult patients with dermatomyositis, and over 50% of dermatomyositis over 65 have an underlying malignancy. Basic screening for all should be encouraged. Colonoscopy in over 50, mammogram for women over 50, PSA for men over 50, pelvic exam and pap smear for all women, and skin screening. So back to our case, patients were having cervical smear, mammogram, and colonoscopy were clear. On our admission, she had a PET scan, which came up clear, and she was having right thigh dysplastic nevus, which was excised, and it came up clear. She was put on methotrexate and folic acid, and I believe the next talk will be about our medication. So to sum up, so raised muscle enzymes, it's important to have a thorough physical examination and history, and basic lab, it can close everything up and no need for further things. The only thing, okay, how can I go back? Okay, sorry. So the only thing that I highlighted today is about rhabdomyolysis, inflammatory and drug-induced. Other causes are listed here, and it's important to pay attention on other, like metabolic, such as hypothyroidism race. We see lots of patients referred by nephrology for high CK without any element of muscle weakness, and they are more of African side, and we don't do any further investigation. So when to refer to rheumatology? So if patient are symptomatic with muscle weakness and persisting high muscle enzyme, and secondary causes were ruled out, and they manifest with extra-articular manifestation, at that time I might send, if your facility having the access for the autoimmune screen, you might screen them initially and send them to rheumatology. And sometimes we see the patient as a direct referrer, and we take over from there. So to take home message, CK is not always representative of a clinical status, and we have to be aware of the red herrings, which is the mimicker, and more than one diagnosis, it's possible. And the time can allow us to have or to know if there is any other diagnosis in the long run. And thank you.